And just make sure you hit record as well. And if everyone else can mute and go off camera until I introduce them, that would be amazing. Well, we'll go ahead and get started. I want to thank everyone on the call currently for attending today and for joining us for our first inaugural Doctors for America Book Club event. My name is Justin Lowenthal. I'm an MD PhD student in Baltimore, Maryland, a board member of DFA and the director of partnerships for Doctors for America. And I'm thrilled to be introducing this event and our initial speakers for this evening. We've started this book club series to really highlight work across the spectrum of physician, public health, and social justice advocacy in healthcare reform, in gun violence, in prescription drug affordability, systemic racism, and social injustice writ large. We're hoping to host at least 3 of these events per year and highlight both Doctors for America members and other leading lights in physician advocacy who are doing this amazing progressive advocacy work. So we're thrilled to be able to start this event tonight with Medicare for All, a Citizen's Guide, which was recently published by Oxford University Press. And I'm hoping that several in the audience have at least had a chance to purchase it and read through it. Medicare for All, a Citizen's Guide is really a fantastic and concise but exploration of Medicare for All, the prospects of it and its perils as we try to enact it in the United States as one among several policy solutions to getting to universal health care. It's really the first book to offer a really realistic roadmap to a policy that by almost all polling is supported by a large majority of Americans of both political parties, including both the policy nuances and the political calculations that are necessary to make it happen. And the authors, who are both physicians, both friends of DFA and members, have a combined expertise across medicine, public health, and government, and this makes this a really clear-eyed and focused guide to one of the most debated, often demeaned, but ultimately likely one of the most transformational public policy debates of our time. The book has forewords by Senator Bernie Sanders and Representative Pramila Jayapal, as well as absolutely glowing reviews by leading lights in health policy, medical humanities, and social justice advocacy, including from Danielle Ofri, Mary Bassett, Bonnie Castillo, Steffi Woolhandler, Jacob Hacker, as well as our very own co-founder and current 2-time US Surgeon General, Vivek Murthy. So with that, I'm going to go ahead and introduce the 2 authors of this book. First, Dr. Abdul El-Sayed. Dr. Abdul El-Sayed is a physician, epidemiologist, educator, author, speaker, and podcast host. His newsletter, The Incision, cuts directly to the heart of the trends shaping our moment. He's a commentator on CNN and now has 3 books to his name, including Healing Politics, Medicare for All, a Citizen's Guide, our current topic. He is also the host of America Dissected, a podcast on crooked media, going beyond the headlines to explore what really matters for our health. He's a senior fellow at the FXB Center for Health and Human Rights at the Harvard Chan School of Public Health and a scholar in residence at Wayne State University. He's formerly the health director for the city of Detroit and a candidate for the governor of Michigan in 2018. And we're particularly grateful for him joining us immediately after breaking his Ramadan fast with iftar just half an hour ago. And his co-author on the book and a dear personal friend of mine, Dr. Micah Johnson. Dr. Micah Johnson is a physician, health researcher, writer, and policy advisor. He has served as a health policy fellow in the US House of Representatives and has advised presidential campaigns on healthcare reform. He holds a Rhodes Scholarship at the University of Oxford, where he studied philosophy, politics, and economics, and he received his MD from Harvard Medical School. He is currently a resident physician in internal medicine at Brigham and Women's Hospital in Boston, Massachusetts. So Abdul and Micah are going to start off by giving us sort of an overview of the book, contextualizing it, and talking about what the overall goals of the book are, and we'll then launch into a discussion with two of our guest discussants. So take it away, Abdul and Micah.
Fantastic. Well, it's always a privilege to be with the good folks at DFA. Grateful to you, Justin, and the team at DFA for making this possible. Really just grateful for the opportunity to talk about this book. And also want to note that we're a bit Y chromosome heavy on this panel. I've just got to say that the contributions that our female colleagues have made to this issue are immense, whether it's Steffi Woolhandler, or folks like Elizabeth Warren or Dr. Victoria Dooley. So many amazing women who've been pushing for this. My guess is that they're too busy really making this happen. We're just busy talking about it. So honored to be with you all today, and I want to give you some context for why we wrote this book. From my perspective, at least, I come at this conversation from my experience in politics. I ran for governor of Michigan in 2018 on a single payer platform, and then was a principal surrogate for Senator Bernie Sanders when he ran in 2020. And one of the main takeaways from those experiences is that I think we're coming at this question of health reform generally and Medicare for all specifically in the wrong vein. I think the political arena is not the best place to be talking about how it is that our healthcare system affects people's lives. And instead of the big political conversations about state and federal budgets, we wanted to take this back and situate it in the kitchen table budgets that really matter so much to everyday folks in this country. And we believe that if we're able to get this conversation back into the place that it belongs, we have an opportunity to penetrate through a lot of the opacity that the industry has benefited from around a conversation. People know that their experience with healthcare is subpar. They know that our healthcare system is broken, but they don't necessarily know how those two things meet. And our goal was not only to connect those ideas, but also to connect people into the conversation about broader health reform so that they can find themselves in those conversations. Micah?
So thanks so much for having us. Always a pleasure to be involved with Doctors for America. And thanks to Justin and Angie and Allison, everyone else from DFA who's responsible for making this event happen. And for me, I come to this issue as someone who's always believed that healthcare is a human right. But then I got to medical school and started out as a doctor and saw how far we have to come. Even in the state where I practice, Massachusetts, we're lucky enough where almost everyone has some kind of health insurance. And nevertheless, it is a daily occurrence when we see the ways that we just come up short for our patients, whether patients can't afford their medications, whether they've been afraid to get care for decades because they don't know how they're going to pay for it, or afraid to go in when they have an emergency, or they do go in when they have an emergency and end up on the brink of bankruptcy. And in all these ways, it made me realize that to make healthcare a human right, it's not just what I used to think, which is that, well, most people in the country have healthcare, and all we need to do is just get the last few people into the system. I think that now is a mistaken way of looking at things, because the system that we have now, even for people who it's supposed to be working well for, folks who have health insurance are still being let down. So that's what led me into this issue. And I think during the conversation this evening, that's really the question that I'll have in mind, and I hope that you'll have in mind too, is that what would it really take to make good on the promise of making healthcare a human right? So Abdul, why don't you tell us a little bit about the history of what we're talking about today?
Yeah, thank you, Micah. I want to situate this conversation in the context of the first time that our federal government took it upon itself to do that thing stipulated in the preamble to the Constitution, promote the general welfare. And let me read to you an excerpt from the book, which speaks directly to that. As early as 1798, the Fifth Congress passed and President John Adams signed an early attempt by the fledgling republic to promote the general welfare, an act for the relief of sick and disabled seamen. At that time, international trade was vital to the well-being of the United States, although being a sailor was a particularly dangerous trade. To protect its merchant marine, Congress passed the law creating a system of government-run hospitals for seamen, funded by a mandatory tax on their earnings. As science advanced through the 19th and 20th centuries, American government acted as a catalyst to convert new knowledge into broad improvements in general welfare, improving sanitation, putting fluoride in drinking water, ensuring widespread vaccination, funding new hospital construction, and guaranteeing health insurance for senior citizens. Modern healthcare has developed tools that humanity couldn't have imagined in 1787, from vaccines and antibiotics to robotic surgery and targeted immunotherapy. Because of these advances and so many others, nearly 250 years after the people of the United States ordained and established the Constitution, American life expectancy has more than doubled. And yet, perhaps by the standard of our time and the power and wealth of our country, we are yet failing to promote the general welfare. Life expectancy in the United States is nearly 6 years shorter than in Japan, the longest lived country in the world. American infant mortality ranks 55th in the world, and American health disparities by race and socioeconomic status are among the world's steepest. Perhaps worse, life expectancy has stagnated, even falling for 3 straight years between 2015 and 2017. Rather than the infectious diseases of the past, the diseases with a predilection for the young today are diseases of despair: drug overdose, alcohol misuse, and death by suicide. For the population at large, cancer and heart disease are the top killers. For this mediocrity, Americans pay by far the steepest price for healthcare in the world. We spend 18% of all of the money in our economy on healthcare. We're projected to spend $12,000 per person on healthcare in 2021, double the average in comparable countries. And our costs are increasing rapidly. Those increases have fallen hardest on poor, working, and middle-income Americans. 1 in 10 Americans have no healthcare coverage at all. Those who do are seeing their annual insurance premiums explode, even as that insurance comes with rising deductibles and out-of-pocket costs that leave families financially and medically insecure. Indeed, more than 2 in 5 Americans who received a cancer diagnosis depleted their life savings within 2 years. Americans mostly agree that our system ought to provide accessible, affordable, dependable, and equitable healthcare to all Americans. However, we differ dramatically on how to do that. Some prefer government directly take up the cause laid in the Constitution to promote the general welfare. Some argue that healthcare is best left to the free market. Others sit somewhere in the middle. I'll leave it to Micah to take it from here.
Thanks, Abdul. And American healthcare is an enormous topic. It affects hundreds of millions of people, and trillions of dollars are at stake. But as doctors and medical students, we like to think of things one patient at a time. So the passage that I'll read this evening is the story of Lisa, a patient that Abdul and I got to know while writing the book. And I think the story really shows both the problems that we're dealing with in the status quo and raises the question of how Medicare for All could make things different for folks like her. Lisa Cardillo will never forget her 15th wedding anniversary. After waving goodbye to their 3 children, Lisa and her husband Dominic drove across the state to Granville, a few miles from Lake Michigan. They had more than their anniversary to celebrate. Dominic, who'd suffered a malignant brain tumor at just 33 years old, was 3 years past his cancer diagnosis. They were eager for a fresh start. But just as they were about to enjoy the day on Lake Michigan's sandy beaches, Lisa felt a sharp burning in the center of her chest. Then came the crippling nausea and abdominal pain. Though Lisa was 36 years old and otherwise healthy, she knew that something was terribly wrong. The Cardillos knew better than to call an ambulance. Dominic's had cost them $800 when he was first diagnosed. They rushed to the car and started Googling nearby hospitals. Dominic stepped on the gas. Lisa's left arm started to go numb. As Lisa walked into the emergency room, she went into cardiac arrest. With her heart no longer pumping blood, she crashed to the floor. The emergency room personnel started performing CPR then and there. Over the next 9 agonizing days at that hospital, Lisa was diagnosed with a heart attack caused by spontaneous coronary artery dissection, a deadly tearing of one of the arteries that supply blood to the heart. Thankfully, Lisa survived, but that was just the beginning of her ordeal. Because all of this was extremely expensive. The hospital sent a bill for $185,460. For 5 months, she had to wear a defibrillator vest, which was another $5,000 a month. Then more bills for cardiac rehab, follow-up appointments, and prescriptions. And here's the thing. The Cardillos have health insurance. Unlike the 30 million Americans who don't have it, they have coverage through Dominic's job as an automotive engineer. Before Dominic's diagnosis, they had tried to save on premium costs by choosing a plan with a high deductible, meaning they need to spend more before insurance kicked in. That left them with $12,000 in uncovered medical bills. Their friends eventually started a GoFundMe page and threw an in-person fundraiser to partially allay their debts. Together, their friends and families raised nearly $8,000, just enough to get them back on solid footing. But when January 1st rolled around, their deductible reset, and they found themselves back at square one paying for Dominic's ongoing treatment. Beyond the financial toll, there was the personal toll. Lisa spent hours on the phone with the various hospitals, clinics, labs, and imaging centers where they owed money, not to mention pleading with their insurance company to cover the cost of this or that treatment. More than once, she found herself crying to the faceless insurance bureaucrat on the other end of the line. When your medical bills become more stressful than your husband's brain cancer diagnosis, something is not right, she told us. Morbidly, Lisa jokes that her favorite bill is the one for cardiopulmonary resuscitation, the manual CPR she got in the emergency room. For $568, the hospital personnel saved her life. But because she hadn't met her deductible, she paid for it out of pocket. It's the best $568 I ever spent, she said. But should she have had to spend it at all? So I find Lisa's story powerful because it shows that even people who are supposed to be doing well in the current system, people with good, so-called good private health insurance, it's just not there when they need it most. And I think that's a big reason why Medicare for All has risen in the political debate, because we're at a point where a broad swath of the American public is getting hurt by the system, even folks right in the middle like Lisa and Dominic. So what is Medicare for All and how might it change the experience of folks like Lisa? Well, it's a simple idea. Under Medicare for all Americans would have comprehensive health insurance under a single publicly funded plan. So that means health insurance would be universal. So it wouldn't just be for Lisa and Dominic, it would be for everyone. But just as importantly, it would make health insurance comprehensive. So by getting rid of the high deductibles and high out-of-pocket charges for care, and also making sure that a broad network of services and providers are covered. And then it would also tackle our cost problems head on. It would cut out a huge part of the administrative cost that drives up expenses in our system. And then also by having Medicare for All negotiate on behalf of the whole American population, that negotiating leverage would bring down prices for prescription drugs, hospital stays, and doctor's visits, all while funding the system in a more progressive manner that takes the burden of costs off of low-income and middle-class folks. But of course, there's a lot of politics between where we are now and getting to something like Medicare for All. So Abdul, why don't you talk to us about the moment that we're in?
Yeah, I think for a lot of folks looking at this moment, especially if you're using presidential politics as your barometer, it may feel like we are the fight for Medicare for All is behind us. But I would argue that actually, especially when it comes to presidential politics, we're at a local minimum. But if you pay attention a little bit more granularly, for example, to Congress, where Representative Pramila Jayapal recently reintroduced the Medicare for All Act, you see that it's got more co-sponsors than it ever has before, including extremely powerful people like Frank Pallone, who's nobody's progressive. And that tells us that there's a lot of movement yet happening right now. And even if Medicare for All is likely not going to happen in this administration, I'd argue that what we do during this administration is going to dictate whether or not it actually happens. And I'm bullish on that because I see people coming together, having the conversations, organizing with their loved ones, their neighbors, their friends and relatives around the central questions that Medicare for All would answer. And if you look at what that's going to come down to, our history is rather instructive in this regard. It has always come down to advertising versus organizing. And the industry is going to spend millions, if not billions of dollars to try and defeat this through disinformation that they buy and sell in 30-second or 1-minute ads. What we can choose to do is come together and organize with one another to take this on. And that's what's delivered every major health reform in the past. And so there is a lot to look forward to, a lot that needs to be done. And it's in this context that we're really excited to have this conversation. I'll pass it back off to Justin to kick off the conversation today.
Abdul and Micah, thank you for that overview and just for spending the time really writing this book at a time when the political moment really was pretty uncertain for a lot of us in terms of what was going to be possible, even whether any expansion of healthcare coverage at all and some of our social justice and equity goals was going to be feasible. And so I'm grateful to both of you for being here and to all of our attendees. I do want to remind our attendees that to please use the Q&A feature in the Zoom window, the question and answer feature at the bottom of your window, or the chat to ask any questions that you have, or provide any comments, any opinions, or any points that you'd like the authors or our discussants to address. We really want this to be an open discussion and welcome any questions that you have. So with that, I want to introduce our discussant for the evening. We are honored to have Don Berwick with us tonight. Don Berwick is one of the leading scholars, teachers, advocates, and health policy experts in the world for the continual improvement of healthcare systems. He's a pediatrician and a longstanding member of the faculty at Harvard Medical School. He founded and led the Institute for Healthcare Improvement, now the leading global nonprofit organization in its field. Was appointed by President Obama as administrator of the Centers for Medicare and Medicaid Services, or CMS, where he served in 2010 and 2011. And he has counseled governments, clinical leaders, and executives in dozens of nations. He's an elected member of the National Academy of Medicine and the American Philosophical Society, has received numerous awards, and most interestingly to me, in 2005, was appointed by Her Majesty Queen Elizabeth as an honorary Knight Commander of the British Empire, the highest honor awarded to a non-British subject of the British Empire. And so we're thrilled to have him here today to provide some contextualizing comments and help respond to any questions that our audience has. So Don, take it away.
Thanks a lot, Justin. Let me make sure, can you hear me okay? Is the audio working? Great. Well, it's a great privilege to be with you. And I want to thank DFA for this opportunity, but also for everything you're doing. It's an incredibly important organization. I'm proud to be associated with it. I also want to acknowledge my respect and admiration for Abdul and Micah and what they've accomplished in the publication of this book. I got to see the book in manuscript, actually, and the comment on it. I knew right away it was going to be an instant classic. There's nothing published that I'm aware of on comprehensive government-sponsored health insurance, Medicare for all, that's even close to this one in its comprehensiveness, its scholarship, the depth of its rooting back in the history of social insurance, and in the way it explains both what Medicare for all is or could be and what it would accomplish. So buy it and read it. I think I want to make my short comments a bit personal about my take on Medicare for all, which isn't identical to Micah and Abdul's, but I want to explain what brought me there. Although I'd run Medicare and Medicaid, and was immensely proud of being able to do that job, and enormously respectful for these crucial assets in the American social insurance system. I was not a Medicare for all advocate even when I left that position. I knew we had to reach comprehensive coverage, but I thought an incremental approach would get us there. Then I ran for governor. I think Abdul may have been more successful than I was, but I did get to run for governor of Massachusetts, had a wonderful 2-year experience. And yeah, I immersed myself in the public policy issues of state level government. And the facts were tough. You know, I'm highly progressive in my stands about what I think we should be doing with government and public policy. I care about, you know, all domains of support to communities and individuals, especially vulnerable individuals. But in Massachusetts, over the 13-year period before I ran for governor, every line item of state support to progressive policies was down. Parks and recreation down 25%, early childhood education down 30%, restorative justice programs cut in half. Many of them, state-supported higher education, 35% down. Every line item was down, except healthcare. In 13 years, it had gone up 72%. Healthcare was confiscating resources from all these other important public duties, public obligations. And when I went to the private sector and talked to small businesses or large ones, their first topic was healthcare, eating them alive, eating into their competitive advantage in a global marketplace, eating into their ability to do for their workers what they want them to do. And when I talked to labor, their first concern was healthcare. Could they be secure? Would they have it? Or would the story that Micah told a few minutes ago be repeated in their lives? Healthcare was taking more than its fair share. Beyond that, I knew from 35 years of work on healthcare quality that we weren't getting value for this nearly double the per capita expenditure from of other countries. I know the data, and there's always seemed to me to be 3 major goals that we need in this nation to get us, I guess, into a modern and compassionate era for care. One is to get everybody covered, and we're not. 30 million people left out, another 50 or 60 million with inadequate coverage. So we're not even in the landscape of civilized, compassionate Western democracies with respect to healthcare as a human right. That's one. Number 2 is quality. That's my field. I know what goes wrong. I see it every day. I see the data, issues in patient safety, issues in evidence-based care, issues in patient-centeredness, waiting times, problems with you know, soaring problems now, soaring awareness of problems with equity and the racism embedded in American healthcare as it is in much of our country. So there are massive quality issues. And then there's the causes, the causal system for illness. What makes us sick? Why do we get heart attacks and strokes and cancers and depression and injuries? And that those are the social determinants of health. Embedded in our communities are the causes. And we don't work on those. We're not putting our money in the causal system. We're running a massive repair shop without fixing the roads. And it doesn't make sense. So the 3 problems of quality, the coverage, the quality of care itself, and social determinants are not getting attention, even at nearly double the expenditures of the next most expensive country. And then there is cost itself. I wrote a paper in JAMA in 2012 estimating with the RAND Corporation, extensive research that we did, estimating about 35% of American health care costs are purely wasted. The biggest pot of waste is administrative complexity in a highly complex system of payment and billing and coding and record keeping. But there are many other categories of waste as well. The triple aim, the Institute for Healthcare Improvement's triple aim, which I brought to CMS, is better care for individuals, better quality, better health for populations, social determinants, and lower per capita cost, all of which are eminently achievable in this country if we were to design and conduct healthcare properly, and all with the underpinning of healthcare as a human right. 4 goals: healthcare as a human right, better quality, working on causes, and lowering per capita cost. Could we get there as we are now? I don't think so. The incumbent distributions of resources in healthcare, which are rather self-satisfied, a lot of people really doing very well economically, doing very noble work in healthcare, they don't want to see major change. The fee-for-service payment system itself encourages a kind of fragmentation and separation of work. And the insurance system drives us nuts. It doesn't allow us to move money where it's needed, and it wastes a ton on administrative costs. There may be ways to get to universality, better quality, working on causes and lower cost short of a national health insurance system, but it's our straightest shot. And so during my campaign for governor, I switched my platform. I became a Medicare for all, or I called it at the time a single payer advocate in 2013, and I've never lost faith in it since. Politically tough, conceivably impossible. But I think what Abdul is reading in the tea leaves is right, that the sense that something basic is not structured properly and that we need to get to a simpler way to our goals as a nation, compassionate nation, a generous nation, one able to really make care and health ever better. I think there's growing awareness there is a straight shot, and it's national health insurance. It's pulling the payment system under one roof with public accountability and transparency, able to move resources where the resources are needed, and ending the senseless waste of bureaucracy that costs us probably around $400 billion a year, pricing games that are directly derivative from the complexity of the payment system we have, and a failure to put the money where the money really is needed. So it's the best shot we've got. Will we take it? Not yet. But I think what DFA is doing in inviting this conversation, what Micah and Abdul are doing by explaining this, it's the step toward what we need. Meanwhile, I'll work as hard as I can to achieve those 4 goals in the status quo, but I think Micah and Abdul have got it right. Thanks, Justin.
Thank you so much, Dr. Berwick. And it's going to be great to have your experience and perspective during what's appearing already to be a robust Q&A. So for that Q&A, I am thrilled to introduce Sanjeev Sriram, who's a DFA member and a ferocious Medicare for All advocate. Sanjeev is a senior advisor for Social Security Works, a grassroots advocacy organization and a partner of ours who is dedicated to protecting and expanding Social Security, Medicare, and Medicaid. He leads the All Means All campaign to make racial equity a cornerstone for Medicare for All. Dr. Sriram is also known as Dr. America and is a health justice correspondent for We Act Radio and Act TV, writing op-eds and making innovative media to draw connections between health policy, inequity, and social determinants of health. Sanjeev completed his medical degree and residency at UCLA, where he served as chief resident in pediatrics. In 2009, he earned his MPH after completing the Commonwealth Fund Fellowship in Minority Health Policy at the Harvard School of Public Health. He's a former co-leader of the Doctors for America Gun Violence Prevention Working Group, and he practices general pediatrics in Maryland at a federally qualified health center, and is one of my idols and close mentors in the advocacy space. And so I'm thrilled he was able to join us today to engage and moderate the question and answer. So with that, Sanjeev, take it away.
Yeah, thanks for that warm welcome. Can everybody hear me okay? Yeah, it's always the Zoom politeness, right? Okay. All right, so I'm gonna jump right in, and please, everyone, feel free to put your questions in the Q&A function like Justin was talking about, and we'll try to get to as many of these as we can. Our first question is about large employers, big businesses. And it's, how would you, quote unquote, sell Medicare for All to large purchasers of healthcare, that is employers, who do not want to jeopardize high value systems like Kaiser? Does anybody feel like jumping in, taking that one? Micah, you went off mute first, so you get to jump in.
Sure. And I think to provide some context, one of the things that we try to do in the book is break down the political landscape of where different groups are on this issue. There are some groups that are clearly opponents. So big pharma, the insurance industry are definitely against this. And then there are a lot of groups that are definitely for this. The progressive movement, nurses, lots of unions are in favor of this. But there are some really important swing constituencies, as we call them, that lie in the middle. And it's not clear where they're going to come down, and we think will make a really big difference in the politics of this, where they do come down. And large employers are one of those swing groups. And I think the pitch that Medicare for All makes to those groups is just as what Dr. Berwick was saying, how employers are being weighed down so heavily by healthcare costs, and they know it almost better than anyone else, because Our healthcare costs in this country are like an iceberg, where what the individual sees is really just the tip. And most of healthcare costs is hidden underneath the water. And most often who's seeing that is the employers. They know what they're really paying for healthcare. So I think the basic point is you have to make employers trust that what they're going to pay for Medicare for all for healthcare is A, less than what they're paying now, and B, that it's more predictable and will stop growing as fast as it has, because it's really just been out of control for decades now. And there are a lot of ways you can do this. Elizabeth Warren's plan try to take a very direct way and say, look, we're literally going to take your current healthcare bill and shave off a fraction of it and call that your employer contribution to Medicare for all. That's one way to do it. Other ways of doing it, if we can get in the weeds, we get into the weeds in the book about, how could you set the tax rates to make people, to make the employers trust that this is really going to save them money. But stepping back, I do think that it's a big opportunity in that if you get the heft of big employers on the side of a reform like Medicare for all, it could really change the calculus.
Sanjeev, can I jump in as well?
Yes, please.
Kaiser Permanente isn't a great organization because it's a great insurer. It's a great organization because it delivers care really well. It has flaws, but it's an integrated care system in which they can put the money where the care is needed. Because they're a payer, they can put the money where the care is needed. If we have a national health system, we can support many, many more Kaiser Permanentes on the delivery side. We could shape the payment system with a unified payment system toward exactly the kind of integrated, anticipatory, digital when possible, well-structured flow that is represented in the best of our integrated delivery systems. So in a way, what I'd say to the insurers, you wouldn't be giving up Kaiser Permanente. You'd be able to get it for the people who really can benefit from it. That confusion between Medicare for all as a public payment system and the misinterpretation of Medicare for all as the government ownership of the delivery of care, that's a very pervasive confusion. And one of the steps we're going to have to take as a country to navigate in that direction is to understand that there's a big distinction there. England has largely chosen to do both, to have a public financing system and a public delivery system. So have the other UK nations, but that's not what's on the table if you read Micah and Abdul's book.
Great. Why don't we keep things rolling and move to the next question? And that is that, so this is also kind of like a selling question. How would you sell Medicare for all to physicians who will worry that their salaries will go down? I know we hear this a lot from a lot of our colleagues in healthcare. And Abdul, why don't you, if you could just share your perspectives.
Yeah, first I just want to say thank you to you, Sanjeev, and to Don for joining us today. I have to say that Don and I, we belong to a very unique club, which is physicians who unsuccessfully ran for governor in states that start with M. But it's a rarefied club, I have to say. And any club that I can be in with Don Berwick, I'll take it. Look, if you look at where physicians are today, one has to actually take that within the broad sweep of history. It is well known to, I'm sure, everyone on this call that the AMA, which is, has been for a long time the principal organizing unit for physicians, was and has been, continues to be on the wrong side of the conversation about expanding healthcare, whether that was the National Health Insurance Plan or Medicare or the ACA. It has found itself consistently on the wrong side. Obviously, in the ACA, it finally got on the right side after a lot of cajoling. It is on the wrong side of this debate too. And that is largely because the AMA is a guild and it represents the way that physicians used to practice medicine. Guilds are a means of organizing businesses as opposed to unions, which are a means of organizing labor. And what has happened over the past 20 years or 30 years, I think is really well put by Dr. Sandeep Jauhar, who wrote a book called Doctored. He said that doctors went from being knights to knaves to pawns in the healthcare system. And what's happened over time is that because of the consolidation, because of the pricing games, that Dr. Berwick spoke to, what's happened is that physicians who own practices have largely been forced to sell, which means that the next generation of physicians no longer have practices to buy into. Instead, they're in effect forced to work for these large corporations. And they don't necessarily see this because it's really hard to appreciate what an earning trajectory looks like over a life course. But early starting physician salaries are actually a bit higher in real terms at the start. But what happens is physician salaries today are completely flat. In the past, what would happen is you would start at a lower salary, and then you would, in effect, become a partner in your firm, and then the partner's business, the business of the firm, beyond simply your earnings as a physician, would help vest, and you would make a lot more money. And so physician earnings are actually down as a function of the consolidation in the system. And in 2018, it was the first year that the median physician no longer worked for a physician-owned practice. It was also the first year that the median physician supported single payer. Coincidence? I'll leave it to you. The point that I'm making here, though, is that physicians have to fundamentally rethink the way that we organize. And rather than organizing as a guild, we have to really start thinking about organizing as a union. And in that setting, right, if you're talking about organizing against major corporations, one of the most important things that you can do, right, is make sure that you have some sort of regulation against your corporate bosses. And Medicare for All in part would do that. But the second point is this: it shouldn't be that physicians are forced into working for large corporations. They should be able to own physician practices. And the best single way to deal with the pricing shenanigans is to have one price for everyone in a particular locale. And the best way to do that is to set that price. Medicare for All could do that through its monopsony. And so in that respect, actually, if you think about what would be in the best interest of physicians over the long term, it would be passing Medicare for All, so that you then could, put up your shingle. And if you run a great, competent practice, you will get patients, you will be able to build your own business, and you will no longer have to worry about some large corporation outcompeting you simply because of their size. The last point I want to say is this: there is a profound lack of imagination in thinking that the same rates that Medicare pays are what Medicare for All would pay. I mean, just profound lack of imagination. And so usually what you hear from physicians are like, well, the Medicare rates are quite low. I would go bankrupt under the Medicare for All. And you're like, well, that's just a profound lack of imagination. Obviously, right, that's going to have to change. But what's important is that it would change in ways that actually value the care that is valuable to patients. Right now, we watch as orthopedic surgeons are making $1.3, $1.4, $1.5 million a year, right? And a starting psychiatrist or a starting pediatrician, Dr. Sriram and Dr. Berwick, right? You're making 150K a year, right? And so that to me doesn't really represent the value in the system. And you could imagine under Medicare for All that would start to shift. And sure, is it going to piss off some specialists? Maybe, but as far as I see it, right, if that means that we are empowering primary care providers in the system, that's for the general benefit of patients. So a few points on that.
Yeah, and the studies on time and money in healthcare actually totally back what you're saying. I mean, I think that it was in 2007 or 8, there was a study describing the amount of time the average physician practice was spending on paperwork, and it was coming out to 3 work weeks a year being spent on paperwork, and costing the average physician practice about $83,000 a year. It's just $83,000 that it's just gone. It's not making anybody healthier. It certainly didn't make anybody working at that practice any, wealthier. It's just like poof. And, and it speaks to, what Dr. Berwick was talking about how we're just extracting zero value out of that money that just evaporates. And so I usually tell my colleagues, if you can think about what you would rather be doing with 3 weeks of your life every year. And I mean, there's no dictates on that, right? I mean, like, you want to go vacation and prevent burnout, great. You want to, do some extra, training, education, hone on your skills, fantastic. You want to see more patients, great. But it's 3 weeks not spent with the insurance company's paperwork. And that automatically means you're getting better value out of the time and the money that's there. The next 2 questions are connected, and one is a policy question that I think feeds into a political question. So I want to ask the policy question first, which is that Are we capable of achieving Medicare for all in one full swoop, or do you think it has to evolve incrementally? And then I'll come back to the political question after we discuss that one.
I'll take a first shot. It's partly a political question. We can't have a national health insurance system without public support for that is confident. The more the public experiences public insurance, or could experience public insurance, the more support there'll be, because it's better. And therefore, some of the ideas that are floating around for a public option, if correctly constructed, could help people taste what it would be like to have the government be your insurer instead of the commercial for-profit insurance industry, or not-for-profit insurance industry. It behaves the same. The problem is this, that the incremental approach doesn't harvest the benefits that Abdul and Micah have written about at the scale achievable. The biggest one is administrative simplification, which David Cutler at Harvard has estimated to be between $300 and $400 billion a year. That's a ton. That's 10% of the bill. You don't get administrative simplification by maintaining administrative complexity. And so the incremental approach may be the only practical way to move ahead politically right now, but it won't be the full bore. It won't provide the full bore benefit that if we went to national health insurance, we would achieve. The other thing to keep in mind is that it's not just the payment system that has to change. We need teamwork, integration, a smoothness of care that we don't achieve in the current fragmented system. And if we keep cutting the payment piece into pieces, then what are the hospitals to do? You know, they have a, you know, what is the phrase? They have one foot on the dock and one foot in the canoe, and they don't know what to do. In a unified payment system, they would know what to do. The signals would be much, much clearer, and we won't get there with the incremental approach. That said, I'm a pragmatist too, and if we need increments now, let's just design the best possible increments, but it won't get us where we really want to go.
If I can just chime in on that, you know, there are two competing timelines. One is the policy timeline and one is the political timeline, right? The policy timeline, ideally, you would want as much time as you could have, right, to make sure that every aspect of the rollout was checked and rechecked, and that you were achieving the maximal possible efficiency, while also making sure that you had a level of safety. The political timeline is precisely the opposite. The challenge is that you know, the high probability, just look at the choreography of a particular administration, is that it would probably have to be passed within the first year or 2 years of an administration. And the challenge is, if that administration is swept out of office within 2 to 3 years, you want to make sure that you are through the deployment before the next administration has an opportunity to, you know, to repeal it. Because the moment, to Dr. Berwick's point, the moment the American public has it, they're going to want to keep it. So the key is, how do you make sure that they have it in as short as a time as possible, so that it's never taken back? One really great read that I recommend everyone pick up is Jonathan Cohn's The 10-Year War. It's a fantastic book about the fight over the ACA, which of course was a far less comprehensive approach to health reform than this. And he speaks to a lot of the ways that frankly Republicans were flummoxed in their efforts to repeal, because the minute people actually had, right, protections against being booted off their insurance for pre-existing conditions, Medicaid expansion, young people being able to be on their parents' insurance past 20 or until 26, people don't want to let that go. And so I think Medicare for all would be the same. And so how you negotiate these two different incentives, I think is worth really thinking about.
And actually, our next two questions kind of are good follow-ups to that. So, you know, both Abdul and Don were involved in the Biden-Bernie healthcare task force, advocating for steps that would inevitably lead toward Medicare for all. And so what, in this panel's mind, are some of those health policy steps we can advocate for that would lead inevitably to Medicare for all? Dr. Berwick mentioned, you know, a public option. And then that kind of leads to the next question of, like, how do you get this policy, whether it's a set of increments or a fell swoop through the chambers of Congress.
I can speak to this. So I think that one thing that's very valuable about the Medicare for All movement is that it lays out a clear vision for health reform. And it says it's a truly universal program. And as Don puts it, it's a straight shot, right? The government is willing to take bold action to directly provide public coverage to everyone. And I think having that North Star in mind is really clarifying, because one of the stories that we trace in the book is the way that the politics of healthcare have gotten a bit scrambled, where the idea of subsidizing a marketplace of private insurance companies, that went from being the Heritage Foundation idea to the Romney idea to the bipartisan idea to the Obama and the Democrats idea. So, we've had this really strange situation where what is a pretty middle of the road market-based approach of the ACA, Republicans oppose it and Democrats are left defending it. And I think that's left with, some confusion in the path forward for healthcare. So what happens when a pandemic strikes and you need to get millions of people health insurance really quickly? And we end up in this situation where, with Democrats in power, still using private insurance as the vehicle to roll out healthcare to more people. So all this is to say that I think if there is a unity around the idea that universal public programs should be the goal, I think that gives clarity to the debates we have along the way. And I think the public option is one good example of that, and the work that Don and Abdul did on the task force in terms of defining some of the key criteria that would make the public option work as well as it can, given its constraints. But the other piece that we're about to come up on is prescription drugs. And the way that I see the prescription drug bills that were introduced in Congress just today, HR 3, it's almost like you take just the prescription drug piece of Medicare for All and debate it on its own. Right? This has the features of Medicare for All in that it is the federal government negotiating on behalf of all Americans directly with the drug companies. And it's also incredibly popular, right? It's like 75% of Americans support it and 15% of people oppose it. So I also think it really gives a good opportunity to clarify where the problem is. These are incredibly popular policies, and I think it's a test on the political courage. Can we get a super popular piece that would make people's day-to-day lives better? And can we get that across the finish line in the next year?
Sanjeev, let me I agree with everything Micah just said. A couple of other thoughts, maybe Micah and Abdul want to comment on it. One is there is a bit of a horse race here. As Abdul said, there's some ticking clocks, and I'll tell you one, which is, even while we talk about progress toward a universal government insurance program, the private sector is making moves as well. And there is, I don't know if DFA has the political, has the energy to grapple with this, but there is some really interesting stuff going on to privatize Medicare. For example, the debate about the public option, if you read the details, what's actually being proposed by some of the opponents of government insurance is that the public option be private, that we take Medicare Advantage, which is private insurance purchased by Medicare, and make that the public option. There's a kind of regulatory capture here in which the payment system is so complicated that the people who stand to make money by keeping it private they have a lot of options here, and they're exercising them. So those of us who favor a stronger government support for the social support system are going to need to be on our toes on this. One other point I'll make about incrementalism is that there has been conversation about state-based universal government insurance. It could be done. It could be done. I'm not so sure it's easier than national health insurance, because you'd have to have a whole bunch of negotiated new conditions for states with respect to their own insurance systems. You'd have to have ERISA waivers. You'd be able to pool Medicare and Medicaid funds and put them under common control. But there is an option. It is there technically for a state to try this out, and we may see that take shape. I don't know, but maybe Abdul and Mike would like to comment on that, because I know they thought a bit about that when they were writing their book.
Yeah, I'll just jump in really quick. First, I do want to credit Micah. He was operating in the background with Don, Representative Jayapal, and I throughout the whole thing. We to crystallize sort of how we thought about trying to advance where now President Biden was to where we hope he will be when he actually starts to move on healthcare legislation, inshallah, to use Joe Biden's words. Is that we wanted to increase the public footprint, we wanted to expand healthcare, and we wanted to reduce corporate power. If we were able to achieve those three outcomes, right, then it would be a step in the spiritual pathway to Medicare for all. That being said, there are some traps, right? The minute you offer a public option, what will happen, especially if it's a truly public option, what will happen is that corporations will race to try and dump their most expensive patients onto the public plan. And then politically, they'll point to the public plan and say, look how inefficient government is, right? It can't even run its own public option well. How are you going to do Medicare for all? And so that's a trap that we have to think about. To Dr. Berwick's point, there, as we sort of think about next steps, this question of, it constantly being, we're constantly operating in a live arena, I think is a really important one for people to think about. And the movements behind closed doors are really worrying. Mike, I've talked to Micah about this a couple of times, and I don't know, we didn't really write about it, but if I'm just putting my political hat on for a second, if I were to be able to step up and say, all right, we have an opportunity to pass Medicare for all, how are we going to do it? The way that I would actually want to do it would be to force states, rather than the sort of the Medicaid expansion scenario where it is by choice, to force states, right, to create their own operational plan for Medicare for all and leverage CMS more as a consultant. So it would almost be like Medicaid for all, because you have 50 different parallel processes to providing the support, and because the money is there, and there's sort of like a penalty that will be drawn in terms of other dollars if it is not enacted. You have the scenario where you don't have one chance to get it right. There's no healthcare.gov scenario. So it's an approach, and to the point that Don also made, there are a number of states that are pushing forward, whether it's New York or California, and I think those are really exciting. I mean, I ran on single payer, Don ran on single payer. It's doable. ERISA is a real barrier. I think even more so than the CMS waivers. But these things are really at the end of the day political, right? Because if you force the administration's hand by saying we've passed this in a state that helped get you elected, particularly if it's a swing state, neither California or New York are there, but we are a precedent-setting opportunity for you to decide how you're going to play this. I do think there's a lot of opportunity to move the administration's hand on some of these things. So it is an interesting space right now, and I think there's a lot more moving than the outcomes of the presidential election would suggest.
I wanted to have one more question before I hand it back to Justin. And, I think that with the George Floyd verdict that we just heard earlier this week, and with a lot of the events that have been going on for the past year around racial justice and injustice, I wanted to talk a little bit about the need for racial equity in healthcare, and how this might be a stronger prerogative in the United States compared to a lot of other wealthier nations. The country is projected to become majority BIPOC by 2040, but a lot of our states are already there. My home state of Maryland, we're a majority BIPOC state. California, a lot of the Southwest is already there. Hawaii has always been there. And even for states that are not, in states like Michigan, where even though people of color are nowhere near the majority of the population, they are disproportionately uninsured. And we all are familiar with a lot of the minority health disparities that kind of expand and ripple out from that. And so I was wondering if we could have some perspectives on how Medicare for All can specifically address minority health disparities in a way that our current system is and perhaps a lot of the other proposals on the table, like a public option, might not quite get there.
Let me jump in on that. So I don't come to Medicare for all or even healthcare policy because I particularly care as much about healthcare as I do about public health. Frankly, people spend 99% of their time in the places that they live and learn and work and play, and maybe 1% of their time, if they're very unlucky, in our clinics and hospitals. And so we spend so much time focused on clinics and hospitals because we've built our entire public health apparatus and infrastructure around that interaction. I think that's part of the problem. One of the things that Medicare for All does is it de-sequesters that 18% of our economy that we spend on healthcare and allows it to move back into the spaces where we ought to be thinking about addressing ill health. And let's be clear, the air you drink, the water you breathe, the house you live in, the job you work, the school you go to, all of those things pattern health for lower income people in much more profound ways than they do for upper income people. And because of structural racism in our country, right, Black and brown people are more likely to be lower income. And so you take those things together and you realize that one of the most important things we can do is start investing truly deeply in public health, which requires us to fundamentally rethink our healthcare system to address the disincentives that exist there. And so it maps clearly to me because of that problem. The second problem, though, and this gets to the healthcare question, is that not only are Black and brown people more likely to be uninsured, they're also more likely to be Medicaid insured. And let's be clear, right? Medicaid is like half insurance. Now, I hate to say it, but it just doesn't command the same reimbursement rates. And so the knock-on effects in the healthcare system are that clinics and hospitals, like clinics don't locate in these communities, and then hospitals tend to get bought up by these for-profit providers who are looking to nickel and dime left and right. And that leaves people not only without insurance, it leaves them without high quality healthcare access. That's a particular problem also in rural communities, right? Let's not forget rural disparities where the same problem exists, but then it multiplies, it compounds on the fact that you have low density, which makes it even harder to provide healthcare. So you take those things together and it is a fundamental driver of our inequities. And one of the most important things we can do to solve those inequities is to solve the disincentives that keep sucking money into the clinical encounter, right? And keep creating, in effect, second, third class status for Black and brown people whose healthcare is not reimbursed appropriately.
I'll comment briefly, Sanjeev. My campaign slogan when I ran for governor was all means all. And that's the first answer to your question. It's don't leave everybody out. And this is, as Micah quoted me, the straightest shot to doing that. Everybody has coverage, period. That itself will begin to allow us to work against the inequities that develop as people get left out. Second, the flexibilities that Abdul talked about. We are frustrated because we can't put the money where the causes are. In a unified payment system, that becomes possible if we change what we buy. And that's part of what Medicare for All better mean, which is changing the way we think about buying health and well-being and care by focusing on integrated care systems and on prevention and public health as well. Third, and very important to me, is we can set goals. This country, for example, is unable to set a goal today to end the deaths from opioids or to close gaps in maternal mortality or to make sure that all kids under 5 are school ready. We just don't do that. We're not a goal setting nation except in wartime or with respect to certain areas of policy. This allows our nation to make some decisions altogether about what we'd like to accomplish. And one of the things we'd like to accomplish is closing gaps in health status based on race and the vestiges of structural racism. We can't set goals without this, not at the level that would really make a difference for the nation as a whole.
I'll also comment, and then Sanjeev, you're a national leader on this issue, so please, I would love to hear from you as well. So kind of picking up where with Abdul is saying, one way of breaking down the data is that the majority of white Americans have private insurance, and the majority of Americans who are people of color have public insurance. And that gets down to the payment disparities that Abdul is mentioning. And Medicaid in particular is just paying less. And that leads us to confront the logic at the core of our healthcare system, which is that we pay differently. We value bodies differently based on the amount of money in the bank accounts and the color of the skin. And, I've tried to run these numbers myself. Maybe it's a 10% or 20% reduction in payment for taking care of a person of color rather than a white American. And that is just baked to the core of this fragmented healthcare system, where you divide people up across income and class and race into different categories and then treat them differently. And it's really, really hard to see how that can change with keeping the fragmented system that we have.
Yeah, and I mean, I think that this also just speaks to why, a huge part of why COVID was so devastating for communities of color, no matter which state we're talking about. Communities of color suffered under COVID largely because of this fragmentation. They were working in jobs that had, little to no benefit, very few workplace safety standards whatsoever. There's no paid leave, so you don't want to risk losing your job if you get sick. And then if you do decide to take time off to go to the doctor, there's a ton of financial obstacle courses waiting for you, as far as whether you want to get care or tough it out. And I think that all of us have seen patients go through this, and I think that with Medicare for All, we can actually start tapping into our communities of color's potential in ways that I don't think that our social policy is used to thinking of. We don't really think of poor single moms and Latina or Black communities as economic drivers, but there's no reason why they shouldn't be. Their hopes and aspirations can really come to life when we take this burden off their back of should they be paying the copays for a doctor's visit, or buying their kids school supplies, or maybe paying for that extra course at the community college to get certification in something that they've always wanted. And I think that the idea of unleashing people, everybody's potential, by making healthcare something that is just sort of a routine chore, and not this this false choice of oh man, am I going to lose my heat because I decided to finally pay up for prescriptions that I've been putting off for too long. I think we can end those false choices. I really feel that there's a way that we can tap into human potential that we've never done before. And I think that's how Medicare for All ends up paying for itself, is just, what happens when you finally are really welcoming people into their freest, fullest selves that, they currently are not able to do. I want to really thank this panel. I know that we've gone a little bit over time. I thank our audience for staying in tune. I'm going to hand it back to Justin. I think that there was a few announcements that he wanted to make, and we'll close it out.
Thank you, Sanjeev, for joining us. Thank you, Don, for the really helpful context and discussion. And a big thank you to Abdul and Micah for all of the work that you've done, and for reading and putting this book out there. I think it's going to be hugely important and hugely helpful to us here at DFA, and to physician advocates who are looking to help win this fight. The book is, as you can tell, absolutely fantastic. For those in the audience who have not already purchased it, please consider doing so. We've partnered with Greedy Reads, which is an independent bookstore in Baltimore. And we're looking forward to partnering with them in the future as well. And that link is in the invitation email. You can also purchase it through your own independent bookstore, or if you prefer to use Amazon, use the Amazon Smile program and elect DFA as your charity benefactor. The survey for tonight's book club, the first of our book club series, is in the chat. So please take some time, either by clicking in the chat or clicking in the follow-up email, just to let us know how we can make this better, if you have ideas for future books and future authors to feature. And then our next event is scheduled for July 22nd. We'll discuss the book by psychiatrist and DFA leader Dr. Bob Larson entitled Wounded Workers, Tales from a Working Man's Shrink. Dr. Bob, who's a proud and valued member of our gun violence prevention team, recounts compelling stories of America's workforce subjected to physical and psychological trauma just for doing the work that they do every day. These are stories from the trenches, from him as an occupational psychiatrist treating patients subject to ill fortune, shootings, amputations, sexual assault, healthcare-induced disability, and they come alongside his own personal journey from being a working class kid to a scientist, a physician, and a professor, intertwined with the dynamics of victimization and advocacy. And so it's going to be a wonderful discussion. There's already been several ideas in the Q&A and privately about future books, and we're really looking forward to these events in the future. But with that, I want to, again, thank Abdul and Micah, as well as Don and Sanjeev for joining us. And thank you all for attending, and hope everyone has a good night. Thanks so
Justin,
much.
thank you. And again, Sanjeev and Don, thank you. And Allison and Angie, thank you. And everybody who joined us tonight, really appreciate you all.